Hello, good evening. It's Dr. Radialis tonight in the English version of the Atlanta contribution. So, as always, I like to pick a case that I have seen during the week and that seems to be very interesting, that could help not only the person that we are trying to help, but also somebody out there that could be looking at this video. So, the subject for today, it's going to be what happens when we find uterine adhesions or Asherman syndrome. I want to discuss a few things around that. One, how could you get Asherman syndrome, and the what to do about it. So this week, the patient that came to me, this is her story. She is 34 years old, remarried. She wants to have children with her second husband. Had a successful tubal reversal, and so she came in for evaluation of her tubes. And so we did a saline and a hysterosalpingogram, and in the saline had a very distinct um, irregularly shaped cavity with these areas that were kind of glued together. On the brighter side, her tubes were patent. On the more complex side, what do we do with her uterus? Um, when I ask her about her history a little bit more in detail, she explains that she had a uterine ablation, okay, a few years back, but that she had resumed her periods that had come back and they were essentially normal for a bunch of years, even though she did admit that in the last um, few months they had gotten a little lighter. So in her case, she had the uterine adhesions because she had a procedure, okay, called uterine ablation to destroy the lining of her uterus. All right. Along those lines, any procedure inside the uterus or even in the cervix, I have seen Asherman syndrome from even a cone biopsy. Okay, because it depends on how the body reacts. I've seen uterine adhesions from DNCs. I've seen uterine adhesions from myomectomies, the ones that are inside the uterus. I have seen uterine adhesions from abortions, okay, because abortions are essentially a DNC. So mechanically, something happened to the uterus that adhesions were formed. Another reason for uterine adhesions is chronic endometritis. If you're having an infection in the uterus that is there for a long time, the inflammatory process can cause adhesions in the uterus. And of course, STDs are included in that group, especially chlamydia. Chlamydia can be a silent bad boy, and it's notorious for doing that to the tubes, damaging the tubes and causing adhesions at the tubes. So you can have that in the uterus because it'll, if it gets to the tubes, it goes through the uterus, so you can have that in the tube as well. Having had previous uterine surgery, okay, can also be a reason to create uterine adhesions. So if you had a myomectomy or a C-section that did not heal as good as we would like, it can create uterine adhesions in the future. Okay, so those are the most common reasons to have, uterine adhesions. And of course, this is a different scenario that somebody that will have a a variation from birth, a septum, a bicornuous uterus. That's kind of a different scenario. Okay. So what to do with urine adhesions? Traditionally, you're supposed to go in with the laparoscope, okay? So, and with the hysteroscope, meaning the camera inside the uterus and the camera through the belly button. Why the camera through the belly button? because sometimes if the adhesions are very severe, it is very easy to create a space in the wrong area. Okay, so if you have a second operator that can show you that you are in the right space and you're not, making a hole into the uterus because it's so densely glued down there, then it's kind of a safety measure. A lot of times you do not need the laparoscopy if they're filmy adhesions, if it's not they're not dense, but it's always good to prepare for the worst, expecting the best, right? So traditionally, you would go in and cut those adhesions down. And adhesions, what is that? And that can happen anywhere in the body. It's two tissues that are glued together that shouldn't be, okay? So it's like the uterus should be kind of a balloon and it should just blow up real nice, but then there are areas that are glued. So you have to go in and cut those out. And then you're supposed to leave a balloon in place to avoid those areas to reconnect, and then give estrogen for that lining along those areas that got shaven to grow again and hopefully heal open. Okay, so that is the traditional way of handling this challenge. In my experience, that works, but it works better in conjunction with other modalities that are not as mainstream. And actually I've been combining them more and more. So one is PRP. Okay, so if you do a release or any procedure in the uterus, I love doing PRP, platelet rich plasma, post-op to all of my patients, my tubal reversals to let those tubes heal open, my hysteroscopies, DNC, my laparoscopies. Any patient that I do surgery on, I like doing post-op PRP to, one, accelerate healing, and two, prevent adhesions. Okay, it is documented that platelet-rich plasma will support non-sclerotic collagen formation, and that means the collagen that you normally create and not that the type that is created during the adhesion formation. Okay. It is out there, but I've used it in conjunction with both the surgery and the PRP, enzyme therapy. So if you combine that, you can actually start ahead of the surgery with proteolytic enzymes like serrapeptase and start kind of internally decreasing inflammation and creating those adhesions to be softer, so then the surgery will be smoother. Okay, a lot of times if they're filmy, then the enzymes might resolve the issue on their own. And how are those enzymes taken? They're taken on an empty stomach first thing in the morning and last thing at night. So 1 hour before or 2 hours before meals. I know that with the enzyme therapy and the other stuff that I will be discussing, it's all kind of in the natural, health world, and there's not a lot of documentation. It's all kind of observational findings. But in my experience of combining all of those modalities, that's where the home run is. Okay. And then the other thing is anything that will decrease inflammation, from a low carb diet, eliminating toxins. Of course, that's going to help not only for fertility or egg quality, that's kind of the boom boom, but it helps in every aspect of your life. It really, really does. And then glandular therapy, a lot of the patients that have had consults with me and we've had any either transfer challenges or lining issues, or like this case that I'm discussing, urine adhesions, I give something called utrophin, which is derivative of uterus, to kind of signal the body that, please, I need that to heal. And then you can go into meditation, visualization, and all of those good things that I usually will tell the patient to go ahead and do it at home to help expedite this process. Okay. In her case, we are scheduled for about a month out for her hysteroscopy, and we're going to do hysteroscopy and DNC and breaking down with cautery the adhesions. Also, I put her on triple antibiotics because any inflamed tissue and, you know, her history was a little complicated. I want to load her up with antibiotics if there's any infection that had caused this or complicated this, especially with her history of resuming menses and then them kind of coming back and so forth. And I put her on triple antibiotics. I did put her on the serapeptase, sent her home with homework on visualization and meditation, all the supplements, the keto diet, and then we'll be doing surgery in a month. So she can try to have, use her tubal reversal, see if we can get her pregnant that way. All right, so let's see what you have for me today. So, Miss Tommy, I had 2 C-sections, tube tied and tubal reversal, unfortunately failed, and a very tilted uterus. I have never heard of this. I've had 2 failed transfer. Could this be why? Yes, it could be why, and we should definitely look into it. A lot of times, have you had a recent saline? A lot of times, I like to look at the salines in my office and see, I do most of the salines in my office anyway. And so we look one for that C-section scar. You can actually see it, and you can see C-section scar defect as well. And, look at that, not only whether there's a polyp or not, but really look at the texture of the muscle, okay? Because it could be hinting adenomyosis. What happens when you start cutting into the uterus, you end up, you like it or not, displacing sometimes some of the glands. And what is adenomyosis? It is glands from the uterus, okay, that grow into the muscle. And it is associated with multiparous women, so women that has had multiple pregnancies because of the trauma of the placenta, embedding, and all of that stuff, and people with C-section. One, because in your case you are multiparous, and two, that's that scarring going into the full capacity of the uterus. Okay, that's why when you are, as a surgeon, when I am doing a myomectomy, I try everything in my power to take out the fibroid without going into the cavity and disrupting the lining of the uterus. Because once you start disrupting the lining of the uterus, you can transfer, those glands into the muscle and create, kind of artificial adenomyosis and some challenges thereafter. The treatment is very similar to the stuff that I just mentioned. But it would be nice to, one, look at the texture of your muscle, of the lining of the muscle, or see if there's any signs of scarring, there's any signs of adenomyosis, if there's any fibroids there. See how you responded to the medications during your transfers. How did your lining respond? And kind of dig a little closer. Are we dealing with infection? Are we dealing with scarring? Are we dealing with inflammation due to displaced glands, adenomyosis? Okay, so it would be interesting to see why you had those failed transfers and look into a uterine cause. Is serapeptase safe to take up to surgery day? My homeopath recommended that as well. I heard it's a blood thinner. It is a blood thinner. It, yes and no. It is a blood thinner, but it's not going to be like having Lovenox, okay? The effect will be minimal, and it will not be detrimental for something like a hysteroscopy, even laparoscopy. It's not going to be an issue. Sometimes I do surgery on people that are on a lot stronger blood thinners like Lovenox, for example, and do fine. So yes, you can take serapeptase all the way to surgery day, and I recommend to take it after surgery day to avoid further adhesion formation. Pretty much, if that's an issue from the beginning, like if it's adhesions in the pelvis, it would be a good thing afterwards. Serapeptase is usually well tolerated. Some people get loose stools from it, so I usually will start gentle. protease. It's another one that I've used in the past. Not everybody tolerates protease. Bromelain. There's a joke out there about having the pineapple, right? Pineapple is fertility. Well, I have a theory about that, and it's because of the bromelain. Bromelain, it's fantastic if you use it in conjunction with the serapeptase because it's an anti-inflammatory, but it also works as a proteolytic enzyme. Have you ever soaked a steak in pineapple juice? It'll dissolve it. It'll be like It's the best meat tenderizer out there. Just give it a try. You soak a steak or any meat in pineapple juice. It's full of bromelain. It'll be like soft and mushy. Okay. Is there anything I can do for my adenomyosis? Never pregnant, starting IVF in November. Absolutely. One, I would definitely start you on adenomyosis and endometriosis are close relatives, okay? They're cousins. So I like treating my adenomyosis, especially if it's well documented and severe, okay, with like Orlisa or Lupron. Start somebody on that and then do the PRP and do the enzyme therapy, the diet. I'm missing something. Oh yeah, glandular therapy and cow uterine pills. Okay, and all of that. I've seen wonderful results doing that. I have a patient that I love dear. I have two patients that I love dearly. They're both. One is a successful mother, and the other one is pregnant after 15 years of infertility. I met her 10 years ago. She's been my patient for 10 years. And she did not have adenomyosis, but she had severe endometriosis. And we got her along. She started with minimal, then IUI. She did the whole up the ladder thing, two or three laparoscopies. I lost track. And so she ended up going donor eggs because eventually her ovarian reserve started going down, and she had 4 IVFs after failed, like 6 IUIs, and none of her embryos, worked. So the next logical thing is, okay, so she moved into donor eggs, and they were still not sticking. And after 2 failed transfers with good quality donor eggs embryos, then we kind of revisited her uterus, even though it looked normal, never looked weird with laparoscopy, hysteroscopy. So we put her on Lupron for 3 months. We did serial PRP, the enzymes. We worked on her uterus, and she sent me a picture of her ultrasound with a heartbeat. So I'm beyond excited for her. Who can I see to remove endometriosis? Should I see a NUC specialist, or should I my local reproductive endocrinologist or GYN? It depends on a few things. If you have a GYN that you're comfortable and happy with, they should be able to do your laparoscopy. A lot of the fertility doctors do not do surgery anymore. They kind of focus just on the IVF. Dr. Kills still does his own surgeries. I do my own surgeries. I like the diversity, and I like seeing the patient in all forms and shapes. And there's fantastic pelvic surgeons out there. If it's really bad, you might want to consider a GYN oncologist, even though it's not cancer. But sometimes endometriosis gets so bad that you really want a very, very skilled surgeon. And from the GYN ranks, the top of the top are the GYN oncologists because of the type of surgeries that they need to do. Getting ready to transfer in 2 weeks. I have a mild septum. Okay. We're going to use Neupogen to help, but any other advice to help, it's stick. It is my first transfer. I've never been able to get pregnant, and I also have PCOS, but I've seen what looks like implantation spotting in the past. Trying. Okay. It's your first transfer, so many blessings to you. If your transfer, and I don't want to jinx it, if your transfer fails, we need to look at your uterus. And if you're saying that you have never been able to get pregnant and you feel that maybe you've had biochemicals, then even more so, you might want to consider taking care of that septum. And then looking into endometriosis, because sometimes I've seen this before. Sometimes people come to me with a diagnosis. Oh, I have PCOS. But PCOS can happen with endometriosis. PCOS can happen with adenomyosis. I had a patient once, she had a tubal reversal, and then she kept having failed IVFs and failed transfers. And kind of nobody thought, okay, is there something else? Because it didn't make sense. So I ended up doing laparoscopy and we found endometriosis. So we ended up taking out her tubes and cleaning things out, and bam, her next transfer worked. Okay. So I know it's kind of a hard decision sometimes to make, but I would definitely focus on kind of working on that uterus if your transfer does not work. Things to stick. I'm a PRP lover, user, and advocate. So that's what I would do. I like doing my PRP early on. I know that the literature talks about 24 to 48 hours. I like a week before transfer. I like 5 days, 3 days before transfer to have a little bit of additional effect on that lining. Is AMH of 10 a sign of PCOS? Is that a bad number? I'm 30. I also have blocked distal tubes and possible hydrosalpinx. Is tubal yes. Tubal removal, highly recommended. Okay. Swollen tubes are a sign of infection or old infection, and they are a reservoir of junk. Junk is not conducive to a healthy pregnancy. And 10 is a sign of PCOS. AMH of 10 is very high. The average, kind of the normal range for AMH is like 2 to 6. So 10 is definitely high. That is not a bad thing. What I've seen with PCOS patients is that they fall into two categories, and you have to be very careful to navigate them. You have the very sensitive, and then the AMH, it could be, I just had a patient with an AMH of 15 and her IVF sucked. Why? Because you have the PCOS that are real sensitive, that you give them a little bit of medicine and they got 30 eggs. Okay. You have to treat those patients in a certain way, because you have to be, one, gentle, and two, you want them to make a little bit less egg so they can mature the eggs. Okay. So then you really want to bring that dose down so you mature them a little longer, because sometimes what happens is they get a lot of eggs and then half of them are immature. And then you have the resistant PCOS. You have the ones that will not ovulate on oral Clomid, will not ovulate on oral letrozole, and then you give them a low dose because you're scared of, the super stimulation, and they're like, they don't do anything. And you go, oops. And so for that group, you want to really help them sensitize. Either group is going to do great with keto, metformin, supplements, and the whole 9 yards. But this group, you have to treat a little different than that group. I mean, you kind of have to go through history, and the IVF process is both diagnostic and therapeutic, but history tells me a lot. Can we just take Lupron or Lisa if we suspect endometriosis? Do we have to have surgery, or can hysteroscopy? Hysteroscopy is not going to determine if you have either endometriosis or adenomyosis, unless there's a mass, right? If you want to empirically just treat with Lupron or Lisa, you absolutely can. And it works. Okay, it definitely helps. Now, in my experience, the magic is when you do the laparoscopy, because you manually clean things up, and even at the end of laparoscopy, we wash your pelvis. Like I really wash that pelvis with like normal saline and wash it, because the solution to pollution is dilution. So just that manual washing of your pelvis will dilute like interleukins and all of the inflammatory proteins that could be there. And boom, you get the Orlisa or the Lupron on board. The effect is a lot better faster. Okay. All right. Can serrapeptase or other supplements help get rid of a uterine polyp? Does it need to be surgically removed? In theory, yes. Now, it depends on how much time you have. I have worked with, for those, I have a doctorate degree in naturopathy. So I do have my holistic patients that still come to see me. And I have worked with very dedicated patients that want to treat their issues just with natural health. And serrapeptase and the list of enzymes and all the supplements that I'm talking about can be used to break down fibroids, for example. But we're talking about a 9 to 12 months treatment with enzyme. So it depends on how much time you have to move to the next step. The magic or the beauty or the good side of surgery is that it fixes the problem right there and then, and you can move on to the next step if you're whatever the next step is. But it can be resolved with enzymes. It just takes a lot longer. We're talking about months of treatment with enzymes to break that down. Sometimes what I have done in the office is kind of stir the pot and do like an aggressive endometrial scratch to kind of steer the spot around. But that would be also a blind procedure. While with the hysteroscope, you absolutely make sure that you get rid of it. Okay. What do you recommend? I have endometriosis and a little adenomyosis. I've had 4 laparoscopies, 2 failed donor egg transfers. I would prefer not to do Lupron or Lisa. I do believe I had endometritis. I would strongly encourage you to consider Lupron or Lisa. And again, depending on how far out your laparoscopy was, potentially do laparoscopy with a month or 2 of either medication. I know that both of them have brutal side effects and you feel like crap. There is something called rescue therapy with norepinephrine that will make the symptoms better. It's a type of progesterone that will make symptoms better. In my experience, people that have endometriosis and failed transfers, you need to address that. And the beauty is you can prepare the uterus. So what I'm describing, let's say you say, okay, for this 2 months, I'm going to do the Lupron or the Orlisa, and then we'll do the PRP. We can treat you for endometritis and do a biopsy and double check. And do the enzyme therapy and do all these things to optimize the vessel where your baby will go. Okay. Do you need to remove calcified fibroids before transfer? It really depends on the size of the fibroid, whether it's calcified or not, and then your personal history. Okay, so if you've had failed transfers after failed transfers or failed IUI or miscarriages, then yes, I would recommend that we do address the calcified fibroid. Okay, can you explain what a dilated tube is? A dilated tube, in the most part, is called a hydrosalpinx, and essentially it is an inflamed tube filled with kind of a liquid. When you go into laparoscopy, that liquid tends to be gooey, honestly, kind of mucousy nasty looking. Hydrosalpinx is when it's gooey and more watery. A pyosalpinx is when there is pus in it. All right. All right. Well, thank you so much for joining me. I do every other Wednesday in English and every other Wednesday in Spanish for the Spanish crowd. I'm Dr. Radialis. I'm the Atlanta doctor, and have a blessed rest of your week. Bye-bye.